Welcome, everybody. We're so excited to have Dr. David Young here with us today to share some pearls about eyes, which to me have always been very mysterious and a little bit scary. And sometimes I can't even remember the basic terminology. So I'm probably not alone in having lots of questions about peds optho. And here we are to learn some pearls from one of our favorite guys who, no matter what time it is, will always respond to our texts and messages and come see our kids with his magical little like colored light that always makes them happy. So we're really glad to have you here. And we already went through the opening slides. So Dr. Young, what I usually do when you're presenting is kind of let you go through the whole presentation, but I'll kind of also monitor the chat box. So if there are questions and you can't see them because of your PowerPoint, I'll just interrupt and say like, oh, can you clarify this? Or what does that mean? Or that kind of stuff. And then for like bigger, more conceptual or case-based questions about folks' patients and other experiences, then that we'll save to the end. So there should be a few minutes at the end for questions as well. So without further ado, I'm going to pass it over to you. And thank you so much for sharing everything, not everything, but some of what you know with us, because we need to learn it.
Yeah, no, thank you so much for having me. Summer's been great to kind of help me get everything situated and kind of going. It's my first time doing this type of venue. I mean, not Zoom, of course, but like kind of like this, the iEcho stuff. So yeah, thank you so much, Summer. So I'm gonna try to. Yeah, look, I lost it already. Like, okay, wait, let me do this. I'm gonna do on the more, and then I'm gonna share screen. Yes. Okay, we're good. We're good. So far, so good. Okay, and then I'm gonna do this one. Okay, all right. So, all right, I'm David Young, and then I'm gonna talk about just because basically community type conditions, and mostly question answer or real world kind of like able to talk like in real life, kind of like simple or other families or moms or stuff you had questions. So just a couple eye conditions we're going to go through. This first one, I have no financial conflicts to disclose. Now this is a much closer up view than most people have of people's eyes, okay? And so just to kind of get this real huge eye, we're looking at the cornea clear, so you can't see that, but you'll see the little light reflex, kind of like that little manga, like little thing on their eye, like whenever you shine the light, that's off the cornea. That's the light reflex that's shining off the cornea. The cornea itself is clear. So you can't see if there's a problem sometimes, if there's a scratch or something, it's clear. But behind that is the iris. You'll see the iris here, and then the pupil itself just is space. Just kind of like the keyhole, like looking through. The conjunctiva is the transparent. So similar to the cornea, the conjunctiva itself is transparent, but there are blood vessels in it, and you're actually looking at the sclera behind the conjunctiva. So you'll see the conjunctiva on top of it, just like a way like saran wrap, that kind of feeling. And then behind that is the sclera. And then of course the eyelids. We're actually going to talk a lot about the eyelids today, and I'll show you some schematics of that. Oh gosh, I didn't realize how big these look. Okay, so here's the first common condition. All right, you get some cute baby kind of coming in. You're checking for the well child check, and then but mom's asking like, oh, you know what? There's a lot of tearing. There's some mucus. Okay, so this is the first condition that we're seeing where things look pretty good actually. You look at the eye itself, and the conjunctiva looks fine. You can see the sclera easily. There's no redness. Here's that corneal light reflex again, right? There's multiple here, but all you see is the tearing and some mucus. Oh, this one's a lot more mucus, of course. And you see that kind of caked on here. And yet the eye itself looks nice and quiet, like calm. And even this other eye, kind of not anything that's so threatening. Baby seems fine, happy. But this is an example of a nasal lacrimal duct obstruction. That's probably the most common kind of eye condition that people will ask me about, and then pediatricians take care of it, family practice, they take care of it like on their own, or parents may not even ask about it because they know themselves, right? So, but what makes this, nasolacrimal duct obstruction instead of conjunctivitis? And I was saying how, like, the first thing is that the eye itself is calm. You can There's no redness in the eye. There's not too much guarding or light sensitivity, and the eyelids themselves may be a little irritated because the mucus that's hanging around the eye, it's actually causes inflammation. And this is not a true infection. This is actually more just overgrowth of bacteria because of the blockage in the nose. So here's the kind of anatomy part that we're going to go through, where a congenital nasolacrimal duct obstruction, the baby's born with a blockage down here within the nose. There's this actual membrane that exists, and it is blocking the tears from flowing from the eye. So of course, tears are made. Like the lacrimal gland will make tears. The tears will go and they'll get put into the upper canaliculus or the lower canaliculus, and then into the nasolacrimal sac, and then down into the nose. But the problem here, I got to move my faces here. But the problem here in this side here is where there's a blockage at the bottom, and that causes the tears to back up, and you'll get tears backed up and overgrowth of the bacteria and mucus that's formed. So basically, it's the sink, right? The sink is plugged up. The sink is plugged up down in the bottom here with the plumbing. The sink is plugged up, and so there's a lot of kind of like the drain doesn't flow very well. You'll see a lot of gook around the outside, like kind of mucus around the outside of the lids, and that's where you get this look. This is the nasolacrimal duct obstruction look. So a lot of babies, the tears, they're super thick, and so initially, moms might say, "Oh, look, my baby doesn't cry even," and it's just because the tears are thick. But slowly over time, the tears are created, and when they get blocked like this, you'll get the mucus that's formed around the eyelids. And so from here, this is where kind of you'll get parents talk to you, and the first thing, here's a more kind of defined picture where there's the upper the upper punctum, which is basically the opening of the nasolacrimal system, and the lower punctum. So everybody has these two little dots. There's a dot on the upper eyelid and a dot on the lower eyelid. That's like the beginning of the gutter, basically. Like that's where the tears, upon being made, they get squeegeed into the canaliculus, upper canaliculus, lower canaliculus, and then common canaliculus, and then put into the nasolacrimal sac. You can feel that sac here in the corner between the eye and the nose, and the tears will then drain down into the nasolacrimal duct into the nose. And that's why when you cry, you'll have the sniffles, right, in the theater. That's the normal drainage of the tears. So the babies are born with this valve of Hasner that is still sealed shut. Now so here's a cute baby picture, and you can see the overflow of tears compared to this other eye. You can see the overflow of the mucus. I was talking about how the cornea is clear, and so sometimes we need to use fluorescein or color to kind of highlight a problem. But fluorescein can also be used for nasolacrimal duct obstruction, because sometimes you'll have tearing and you're not sure what it's from. Oh, maybe it's just irritation or allergies or conjunctivitis, or maybe it's a nasolacrimal duct obstruction. The test that you do for nasolacrimal duct obstruction would be, you would put fluorescein in both eyes. So you put the fluorescein in the right eye, you put the fluorescein in the left eye, and then you wait 5 minutes. And then when you shine the light, because with the fluorescein, when you shine the blue light, it'll highlight green. The normal side, the normal side, the fluorescein drains down the normal side into the nose. And so you get the Hanabata here, right? It's not usually that color. This is from the fluorescein. So this proves that this left side is actually open. This is the normal side. The nasolacrimal duct is not obstructed. But on the right side, where you put the fluorescein at the same time, the fluorescein has not come out the nose. Of course, you may not always see it come out the nose, but the idea that the fluorescein is retained in the eye. So that proves that it's not just they're tearing so much, and that's why the tears go down the drain. I mean, that's why the tears go down the face. It's that there's a blockage which has stopped these tears from flowing. So that's confirmation that there is a nasolacrimal duct obstruction. So it's called the dye disappearance test. So sometimes if there's any doubt, or if I have a family that's like kind of hovering over me and they really want to, oh, is this really nasolacrimal duct obstruction? So you could do this as a confirmation test. But I know you guys don't do that usually, but this is just so you know. How is it now? Do you want to do questions right now, or are you guys or random, or I'll just keep going, right, Maya? Okay, sorry, I'm gonna keep going. So
Yeah, I
here's
think you can keep going. There's
going.
nothing
Okay,
in the chat right now.
awesome.
So,
Okay,
but folks,
so
feel free to ask questions if you have them.
yeah, no. So the first thing is, okay, well, diagnosis. And so we talked a little bit about how, like, the fact that the eye itself is calm white, and that there's only the mucus in the child. And if you had to, you can do the confirmation test. And then the next one is treatment. Okay, so I don't know. I put reassurance as treatment, and that I'm not sure if that really is considered treatment. But for me, like, a lot of times the family, if they feel better, then yeah, that's great. They walk out of there with something, because honestly, treatment, you may not need to do anything, right? As everyone knows, right? Like, where 6 months of age, 50% of these kids, it'll disappear on its own. So in a way, you think, wow, it's so common, right? So 50% of the time, it'll get better on its own at 6 months old. 90% of the time, it'll get better by 1 year old. So there may not be the need to do anything, as long as you don't have a lot of infection, and the mucus doesn't bother the parents too much. So reassurance, that pretty good. Takes time often to get better. And then massage, I was saying how, like, sometimes there's like that nasolacrimal sac that you can feel. There was a study a long time ago where they tried to put pressure on the nasolacrimal sac to force the valve of Hasner to open up. But what they did, honestly, was they really mashed it really hard. Most people don't do that, and I usually don't recommend that. But massage is another thing that you could ask families to do, where you're pressing on the nasolacrimal sac, and it's just kind of getting rid of some of the mucus. I try not to put too much pressure on the parents on that one, and that they feel guilty if they're not doing it, because a lot of people don't want to do it. But so plus or minus whether that really is helpful, but it's not medicine, and so that can be done. Antibiotics, if, for instance, there's a lot of heavy mucus and like green, kind of dark yellow, I'll use topical antibiotics to try to help reduce the volume of the mucus. You won't, and I tell parents this, you won't get rid of all the macropia like every morning. That idea of the antibiotics don't cure the blockage. It's just that it can help relieve the kid of a lot of the sticky mucus, kind of irritation around the lids. So a lot of families like that option. And if we're doing antibiotics, then of course I would start with the most basic, least risk of allergy kind of. So often I'll use erythromycin, because all babies get it when they're first born. So you can use ointment or drops, and I'll tell the parents you can use it for a few days in a row. Once the eye is looking better, like there's not as much mucus, okay, stop. And then it might be good for a while, but most likely it comes back. The mucus starts, coming back again, a lot of heavy mucus. Do it again. And you can do it maybe like a few times a month. But if after a while the antibiotic doesn't work anymore, then we probably have to change the antibiotics, because there can be resistance that's created by the bacteria that live in that area. But there's so many types of antibiotics that, often I'll start basic and then can go up if needed in kind of the newer ones if needed. And then, invariably you'll have moms, if being honest. They'll say, you know, I read that I could use breast milk to actually help the nasolacrimal duct obstruction. And again, they're kind of confused with that. It doesn't cure the blockage, but you know, given that there's some IgA in it, it can help reduce mucus. But I'll tell parents, like, you know, there is a risk of infection if you're using that, and there are antibiotics that we could use where we kind of know more what we're getting and what we're doing. So just to, but I'm not totally against it. You know what I mean? It's just that I tell them there are better ways if we really need to. Okay, and then finally surgery. So sometimes if they're still blocked even after like a year or a year and a half, people will send the kid to me, and we could do a surgery to break up the obstruction. And so I'm just gonna, so I'm gonna show you. So under anesthesia, I'll dilate the punctum, those little holes, the little dots that I was saying. Okay, you do dilate that, and then yeah, it gets kind of gross, by the way. I'm so sorry. So like, and then I'll kind of inject that area and probe. Usually we go through the upper lid and we redirect it, oh shoot, back down into the nasolacrimal duct. If the probe alone doesn't help, then another type of treatment is a balloon. It's kind of like where rather than just breaking up the obstruction, we put a balloon in the nasolacrimal duct and we pump it up. And then that kind of enlarges the nasolacrimal duct. That would definitely be second line type of treatment. Most likely the probing alone can work. Here's just a showing you. I mean, the balloon, it's only like 2 millimeters. Yeah, it's like it sounds so big, but it's actually just very small like that. And so that's another type of treatment. So here's the balloon that it goes in all de-inflated, right? So it can fit, and then it goes down, and then you pump it up, and then you keep it for a few minutes. This guy had 2 balloons at the same time. So, and then if it's not working good enough, then you can stent the nasolacrimal duct. You can actually put in plastic tubes to keep it open kind of longer. So here's a kid that has a bicannulicular stent. You can see it going from each side. This is just to show you. And then here's a close-up. Or even a monocannulicular, meaning there's ones that have a foot plate. You can actually slip it in there and it'll keep it open on one instead of both of them. So it's just kind of a magnified view of that. Okay, cool. That was the nasolacrimal duct obstruction talk. And then my second common condition is like something like this. So you can see where, okay, here's a kid, eyes again look really nice and white, clear, but there's all these bumps. Like there's bumps on the eyelid, and this kid has had them for months, right? And so I'm going to talk about 2 things. So, well, styes and chalazions, just to kind of talk about, again, a common condition, because they're related. So first thing is it gets confusing, right? Like, okay, well, when is it a sty and when is it a chalazion? No one's really kind of judging, you know what I mean? Just so you know. But a lot of times the sty is where there's a blockage of the oil pores. And even that gets confusing for parents. Like, it's not the tear drainage or tear anything, but the oil pores along the eyelid, there's like 30. There's also little tiny dots along the lashes, 30 on the lower lid, 30 on the upper lid. They create oil so that your tears don't evaporate too fast, you know. And so there's oil glands or oil pores, and they can get blocked. And so a sty is where there's a little oil pore that has gotten blocked. There is some feeling that there's a slight increase in the amount of bacteria, so there could be considered a bacterial infection at the root. And some people get into the weeds of like the external sty versus the internal sty. I don't think you have to worry about that. Basically, the sty is the acute kind of pimple on the eyelid lash by the lashes. So they're tender, it's swollen. You can see the little whitehead at the edge there. That's a sty. Versus like chalazion, which is deeper inside the eyelid, because the oil pore, the oil gland itself is a column. It's not just a little dot. The column goes deeper within the eyelid. And so the chalazion is actually the body kind of creating like a ball, almost like a cyst of inflammatory tissue, but it's not active. It's actually non-tender, and it's a little firm. And the kids don't care. They're not really bothered by it. They just sit there with this ball, and that's a chalazion. Chalazions can take months. Sometimes it can take over a year to actually get rid of it. So I don't know why I'm attracted to these, but like these cartoons that like people use to remember things, right? This one shows kind of a sty or hordeolum versus chalazion. So the guy on the left, the sty, it's actually painful. It's tender. So if anyone has had one of these, you might know, oh yeah, I don't know why. It's kind of sore. Something's funny over there. And then you press on it, it's tender and red. There's acute inflammation. Um, so that's the sty, and then the chalazion. People don't really notice it. I mean, it looks terrible, like it's a big ball, but it's deeper and it doesn't really bother the kid. So it's hard, non-tender. Another example, these are styes where you can kind of tell, like in the little white head there, and then versus a chalazion. The chalazion being just kind of just non-active. And so because of that, part of what we're doing is, again, in treatment, is reassurance. Like one, in that the sty, it's going to go away. Usually it goes away on its own, hopefully within a few days. And then compared to the chalazion, even that, thankfully not a tumor. You know what I mean? That idea of people worried about, well, what is this bump that doesn't go away for months? Like people are not used to that in terms of the time course for their children. And so reassurance, the chalazion takes time, many months, sometimes a year. If you want to actively try to get rid of it, that's where the warm compresses can help. So warm compresses, of course, they work the best for the styes in that they'll draw it out more quickly because it has a way to get out through the oil pore, and it just adds to the inflammation, and it kind of activates that area. There's more blood circulation to that area. So warm. I tell people 10 times a day, 20 times a day. Even the chalazion, you can try to activate that area with warmth, but it's much more frustrating in that it just doesn't seem to move. It's not so active. But I'll tell people warm compresses. Antibiotics, I don't use a lot of antibiotics for these, although often the parents will want antibiotics. You can use topical antibiotics if there really feels or looks like there's more inflammation or kind of like a worry about cellulitis at all. Then yeah, of course, and you could do antibiotics as you feel comfortable doing. Often I'm doing just topical, unless there is truly like a pre-septal cellulitis and you feel like, oh, then of course we will use oral. But I'm much more talking about kind of reassurance, warm compresses. I have to remind people that when you use the warm compresses, it'll look worse at that time. So don't do it like right before your prom and stuff like that. You got to actually do it like at night. Don't do it right before school. But that's helping bring circulation to the area. Finally, surgery. Unfortunately, like since I get nervous with like knives around the eye, I only do it under general anesthesia. If I'm going to do a chalazion surgery, there's styes. There's no place for surgery, but chalazion surgeries. This instrument has been around for like hundreds of years. Like this is the chalazion clamp. Okay, now I don't know if people have had this done, but in the adults will do it in the office if they have a chalazion in the office. You have one side that has the plate, and the other side that has an opening, and you have the compression torture device that you can slowly close and close onto the chalazion to allow for hemostasis. And here's a picture. So schematic, right? You would use the chalazion clamp. You would put part of it on the outside of the lid, and you would put the opening on the inside of the lid. You would flip the lid to see from the palpebral conjunctiva, and that's where you'd make your incision. You would then use a chalazion spoon to actually dig out the chalazion. I'm so sorry. I know it's lunchtime. I'm so sorry. So and just kind of slowly dig it out, because unlike an abscess, it's not liquid. It's actually hard granulomatous tissue. So you have to actually scoop it out. And then there's no stitches on the palpebral conjunctiva needed. It'll heal on its own. So I might use some more medicine for hemostasis. And then, oh gosh, I'm so sorry. Here's the picture of it being done on a live person. But no one was hurt during the production of this kind of Zoom meeting. And that's it. That's the end. That's the end of that chalazion, and that's the end of this talk. So any questions from anybody? Oh shoot, I have a little thing about running the poll. Do I do that now or later?
I can do it now. We can maybe ask if anyone has any questions, and then we can do the poll.
There was a
Yeah,
question.
kind of. Yeah, let's do questions. Let's do questions.
Okay. There was one question when you were talking about the nasolacrimal duct obstruction, when you said at what level is it? And I thought you said it was the valve, like at the end, like the nasal end of the nasolacrimal duct, but was that correct? Because I answered it in the chat, but I wasn't positive, so wanted to check with you.
So I don't think I did a question on that. But
No,
like,
no,
when you're answering the chat. Okay, I got it. Oh, perfect. That's so perfect. That's perfect. Okay, so the tears are created, and then they go down into the nasolacrimal sac. The blockage, this is not correct. The blockage should be at the bottom. That's actually at the very bottom of the nasolacrimal duct, nasolacrimal system. There's a valve of Hasner, they call it. That's where the blockage is. There are more rare blockages up there, but that's not our traditional, usual, common nasolacrimal duct obstruction. The blockage is down here. So, and that's why too, like I was lamenting that I didn't have a good picture of how the probe that I use, it's not just up here. It actually has to not just go up here, but it has to be redirected down into the nasolacrimal duct. So I kind of compress down there, and it's like, then I kind of pop through a membrane down at the bottom. So that's kind of more like it. You're actually going down into the nose. So ENT sometimes gets involved for, things like this. I've worked with ENT about certain things. They have the advantage, they can look in the nose, right? I can't do that. So, but yeah, that's where the thing is. And then I was so running through it. I'm so sorry, but I forgot to say how, like, for the styes, nobody's pregnant when they have a sty. That's like a myth. Like, there's a Hawaiian myth of like, oh, if you get sty eye, then that means that someone's pregnant, someone that you know. But there's no proof on that, just so you know. And then also, it's not contagious. It's not something that can spread to other. So families will ask me, oh, is it contagious? Because they keep getting it, they keep spreading it. And it's not that they're contagious. It's just that there's 30 oil pores on the top lid or on the bottom lid, and some people are prone to it. And so they might get one on the upper, and then, a week later they get one on the lower. And it's not because it's spreading, because it's contagious. It's just that for whatever reason, they have this setup for these conditions. The environment is what it is. And then even things like diet, like I'll tell you, I don't know of some better diet than others. People will ask me, and there's some anecdotal people talking about, oh, reducing dairy help, but there's no solid proof like that. So we don't know the specific cause, except that people are prone to it.
Can you go back to the picture on the slide before this one with the kid that has like the multiple bumps?
Yeah.
Yeah. So tell us a little, I haven't actually ever seen that clinically. I don't know. Other people in the group, have you seen this before?
Some children are prone to it. And so these are chalazions for sure. And that I was saying how, compared to the sty that is on the edge, kind of like if you think of the wall and there's little openings for your flower pots on the top, that's where the styes will come out. And so the warm compress is so fast, it'll help within a day or two, or it just gets better on its own. But the chalazions are within the walls, deep, and they're too big to just get out there. And it's not just liquid, like I said, it's hard. So it takes months, and they have to escape either from the inside, from the palpebral conjunctiva inside the lid, or from the outside. So you can see how these ones are trying to get outside. And so you'll get like craters created, and it takes months, and they're unfortunately not sightly, and it'll scar, and so these are multiple chalazions, and yeah, some kids are just very prone to them. And
yeah, so that's what I didn't realize that those were. And then yeah, one of our Dr. Will William Ware said he hasn't seen the multiples. I haven't seen that before too. And to be honest, as a non-ophthalmologist, I would look at all that, the cratering and the crusting, and think it was some sort of infection and not recognize it at
Sure.
all. The way that, like, certainly the bump up here on the eyelid, I feel like I would feel a lot more confident in knowing what that is, whereas that looks really inflamed.
Oh no, totally. And you can actually see where the skin itself has, in an effort to remodel and heal, that's where a lot of the erythema is, and so
Yeah.
this is chronic and an older, like these chalazions have been there, most likely for many, many months, maybe
Mhm.
over a year. And of course, I'm showing you kind of like worst case scenario, but unfortunately that it can't happen. So I mean, wait, by the way, I'm not at all against, I'm not saying don't refer. People definitely can refer, because number one, it's so frustrating, and parents want to know, like, oh, that looks spooky, right? That looks terrible, right? So yeah, I'm happy to see people. So I didn't mean it like that. Like,
No, no, I don't think anyone took it that way. There are a lot of more questions, actually. There's one at the top, Dr. Ware, I'll come back to, but Naomi Morita asked, how about eyelash line cleansing with something like OcuSoft to reduce development of obstructed glands? Again,
yeah.
pardon my ignorance, I don't even know what that is. So maybe you could explain
So
for the group what that is and then whether you recommend it.
okay, so like one way to try to, okay, if thinking that the production of styes or chalazions are from things blocking or debris kind of hanging out along the eyelashes, people will sometimes say, okay, you get a lot of styes, you get multiple. Let's try to clean the lashes. So, okay, well, how do you do that? Like, so you don't want soap right in the eye, right? And so some people will use baby shampoo. They'll use like a diluted baby shampoo where you rinse the lashes maybe like twice a week, 3 times a week. That idea of cutting down on the amount of mucus, changing the environment a little bit. But also there are these wipes that exist. They're usually hypochlorous acid. Hypochlorous acid is a type of, I mean, I guess like your white blood cells make those as well. And so it's like a non-toxic type of uh, antibacterial product. So it's legitimate. You know what I mean? People will use it. You can buy it. Um, and some people use that on the lashes. Usually they're using it for a condition called blepharitis. Blepharitis is where there truly is constant like uh, uh, build up and inflammation around the lashes. And so there's overlap with that and styes. So that's reasonable to consider for people who chronically get it. But it doesn't do anything to stop the sty at that moment. It doesn't do anything to cure the chalazion or sty at that time. So often already, like that's not what the kids or parents are usually asking you about. And yet, it's good that you guys have heard about that, because for people who have chronic styes or constant recurrence, we would do that.
And for folks out in the community, what kind of advice would you give to, so say a parent brings in the patient and they've had a chalazion for whatever, a couple weeks or a month, and it isn't going away. What kind of advice do you give them? And then like, about how long they should last, and at what point would you tell them come back if it's not getting better, or I'll refer you to Dr. Young if it's not getting better, at like what point, if it's painful or if it's like stopping you from opening your eyes all the way, or a certain time period?
Yeah, so like I was saying based on this video how like, oh, they're not threatening. That's of course different if it's like a young child, like 1 years old, 2 years old, and it's so big that there's actual ptosis. Like if you actually have blockage of the vision because of the chalazion, if it's that bad, then they should be referred, because one of the worries is, even if it's not, so first of all, obstruction itself, you don't want that for a few weeks in the youngest of kids. But even if it's older kids, sometimes if it's big enough and lasts long enough, it can cause astigmatism. It actually can actually cause a threat for amblyopia. These are the chalazions. And then but painful, any parent that's just really not that they don't believe you, but that they're like, wow, they're just so worried about it. People will send anytime that you're thinking about surgery, because the parents just really not happy with it. And then But people who get them chronically too, people want to have some kind of answer because they just feel like they can't believe it, that there's nothing else that could be done, that they're just so frustrated that it's just not going away, and because it looks bad. But yeah, you
Mhm.
could, so anything like that.
Okay, thank you. Back to the topic of nasolacrimal duct
Yeah,
obstruction. There was a question earlier on asking like at what point would you recommend that they refer to you for that? Again, is there a certain age or is it more about parental anxiety or
yeah,
both?
parental anxiety for sure, both of course, sure. Um, Anything that looks out of the ordinary where like it doesn't look just like that. Like, okay, well, now wait a minute, the eye is super red and it's not getting better after a course of antibiotics. If there's corneal clouding, like that's very, very rare. Like this idea of, congenital glaucoma. Um, if you get frequent infections and the amount of heavy mucus is such that the antibiotics, they're not working well enough. Once they're old enough, like most times it's like, okay, people know that around 1 it should have gotten better by now, and moms are frustrated and it's like, okay, yeah, you're welcome to come anytime. So that is commonly when I'll see. It's funny too because you'd think that again it doesn't affect vision, but there is a statistical chance increased risk of amblyopia. Like the kids that have nasolacrimal duct obstruction of just one eye, somehow that eye is a slightly different, and so they have a higher risk for refractive amblyopia, which seems unrelated, but just statistically that's the case. So sometimes just getting in the system can be helpful for these kids that have nasolacrimal duct obstruction.
Thank you. Folks, there were a lot of questions and we're so happy to see questions. Anybody with other questions? I have one while we're waiting, which is, we have a lot of folks here who are on neighbor islands, or, in the Pacific elsewhere, not here in Honolulu. So it's kind of a big decision to, refer, or you may not have access to at least a pediatric ophthalmologist. What would be some like emergencies that folks should be sure to be able to recognize, that, we might not necessarily know about that could come into your office? Come into your office as a general pediatrician or a family medicine doc.
So meaning like this kind of stuff, like kind of along these lines.
No, out of the not these two because yeah, other than obviously like if you start with a
Yeah,
sty and you end up with an orbital cellulitis, I think most people
yeah, yeah, yeah.
can tell if you have fever and your eyes popping out of
Mm.
your head that that's an emergency. I meant more like, are there subtle things within just the field of peds optho that you're like, oh gosh, I wish everybody knew this. It's really important to recognize blank.
I think the um so the you guys know too, like the red reflex, right? Either some kind of abnormal red reflex. People kind of are not either used to getting the red reflex or they're not sure the timeline of that. But if there is a baby, right? So anyone less than 1 and the red reflex at all seems abnormal, those are ones where there is a risk of retinoblastoma, or if there's cataract, those conditions, cataract, you'd have to do the surgery early enough. Otherwise, they'll have dense amblyopia, which is irreversible. So even if you catch it later on in life, may not be able to do too much. So red reflex test, people kind of have, I don't know, they don't use it as much now, but they should. And that's a very, very handy test to really see things so quickly, and you kind of rule out serious things, uh, kind of in a timely way. And then the other thing would be just making sure when people test vision in the office that they're testing one eye at a time, because I often will get kids later on in life where turns out they have amblyopia, and then they kind of just got through every test because they were cheating, or like they weren't, they got through it and they didn't say anything. And so just really making sure that vision is tested in each eye alone early enough before age 6, 7. Those are the two things that I've seen sometimes get through. And then yeah, that's it. I try hard to make sure the babies are always easy to get an appointment. Sometimes I know it's hard for people to get an appointment for some of the older kids. Um, but if if there's doubts, people could call and I'm happy to see. But Yeah, it's hard for me to think about just kind of out of the box like that for anything else, Maya. Sorry.
No, no, that was perfect. Another thing, I see a lot as a hospitalist that, kids come in with these pretty severe eye infections that require admission, whether it's a preseptal cellulitis or more rarely an orbital cellulitis. And a lot of times at the beginning, folks think that it's allergies. And so, you get the story that the patient had like fever and maybe a little runny nose, and then the eye was swollen, and they got Benadryl at an urgent care, and then like 2 days later they come in and the temp is 104 and the eye is like red all over. And any warning signs for like how to distinguish between an allergic reaction, and other than obviously if it's one-sided, I think that's pretty obvious, but sometimes it does kind of look confusing if it's allergy or
Yeah,
infection. And
no, for
I
sure.
find that tricky.
Yeah, definitely tricky. And then the bad thing, and I wish it was different, but because for a lot of families, kids get colds all the time, and the usual tempo is, yeah, they get sick, yeah, runny nose, they're sick, and then it gets better, right? And
Yeah.
so there's always waiting. They don't want to have to go to the urgent care or the ER or see their doctor, so they wait, and then the bad one was, yeah, you're sick, you end up getting sinusitis, so you don't see anything, and then finally you'll get this orbital, cellulitis, and there's proptosis, and
Mhm.
so I don't know what else to say except that this idea of constant vigilance, or the feeling of letting the parent really be able to contact people again if, oh no, it's getting worse or something, because I agree with you that it seems quick, and it takes us actually getting like a CT scan or something that actually shows us, because otherwise it's hidden. The kid's not trying to show you, they're not feeling good, the parents are resistant to have to do anything else, things don't get treated fully, and that's the way I've seen it as well. So of
Mhm.
course things that look bad as far as the eye being pushed out, or they're being double vision, if they're old enough they'll tell you, oh, because the eye won't move as well with orbital cellulitis, so you get double vision. Um, but the toxic nature of that point, that means it's already been gone pretty far. So, gosh, I'm not sure how else to kind of predict reliably, because sometimes it just gets better on its own when it's in those early stages, and I'm sure
Yeah.
we all had that experience. So that's the nature of medicine. Unfortunately, this one is kind of hidden within the facial structures until you kind of see it really bad.
Thank you. Shall we do the questions really? And then we can go through them and see if there are any that people have questions about, or that maybe if, everyone doesn't get it right, we can review the answers.
Sure, I'll
Does
go.
everyone have to get it right? Because we no, just
No, it's just for learning, so that if everyone gets it right, we don't bother to review it. But if folks aren't sure about it, then it can be helpful to review.
I don't do anything right.
Nope, you just sit and wait.
And while everyone's doing that, next session on May 1st, we have the accurate diagnosis of autism by Dr. Sneed and Dr. Samuelson from Catalyte coming back.
Yeah, another really high yield topic for folks. So we know that, the prevalence of autism has been increasing over the last many years.
So
Let's,
maybe, oh, sorry, go ahead.
I was going to say the same thing you were. Let's do another few seconds and then we'll close the poll and review some of the answers. You also answered a lifelong question for me, which was how to pronounce chalazion, because I wasn't sure if it was a ch or a k.
Now, there's people I've heard that are say Calazion. So yeah,
Oh, yeah.
but I guess where I trained, like in Philadelphia and in Rhode Island, it was Chalazion. But yeah, I know, spooky, right?
Yeah.
Since
One
we
of
have
those words you
That's
don't
why
say
emojis
much.
are good. Emojis are good.
since we have time, could you go over the first 3 questions, Dr. Young?
This is so cool. Okay, so first of all, I'm so sorry because like I was trying to do just pictures and I didn't have the word slide, so that makes it harder too, right? So I and it's not something that people would know except it only I see it sometimes, and there's studies on this where like congenital nasolacrimal duct obstruction somehow there's a risk of refractive amblyopia. So refractive amblyopia being where more just one eye, the vision is not as good as the other because the prescription in their eye, like one eye has a lot more astigmatism than the other. One eye has a lot more hyperopic, right? So that type of amblyopia, we don't know why, but somehow there's something slightly different. So when the kid is asymmetric some way, oh, the nasolacrimal duct obstruction is only on one side, the other eye is not. That kid is statistically at a higher risk for having amblyopia. It's still only like like a few percent, but it's just that's real. But again, me seeing how that didn't come across again, I obviously didn't pay enough attention to that part. So bad, just a bad question. Yeah, I'm so sorry. So that one,
Don't be sorry. It's very
the answer for that,
frequent.
no, that's true. The answer for that is true. And so it's just good to know. So, and then styes are contagious. The answer to that is false. That they're not contagious, although you can get multiple. And the feeling that people have is that they seem to spread, but it's just that the patients that have them, the conditions for their eyelids are such that they get multiple. So they're not spread, they're not contagious. You can go back to school, things like that. I've given notes to families where like they want to go back to school. The school wants them to have a note, but so they're not contagious. And again, I like these when they're close to the middle. It just tells me like, first of all, that the question is not good. There is no role for antibiotics in treating chalazions. And that's one of those things where it's like, oh, it's always this, or it's never that, or there's no role like that. So that's more just like test taking kind of silliness in that if you truly feel like, so for me, I was thinking the answer is false, that there would be a role for antibiotics, especially if the chalazion, like listen to this, has spread to become like, preseptal cellulitis, or it looks like there's some signs of infections on top of the chalazion, but that doesn't give you the whole sense of this question. So I totally understand people in the dark room having to make choose an answer, not knowing which one, because the chalazion itself is sterile. The chalazion itself should not need antibiotics, but I do give antibiotics when needed for cases where like, oh, it looks like there's some infection on the skin or around it, or it seems like it's spreading, I'm not sure. And so again, bad question. And then finally, can last over the year. We got 100% of that one. That was a really good one. They definitely can last a long time. And that's the problem with these things, is that they're annoying, they're big, bad, they're ugly. It's really, it's not fun, but yeah, they can last a long time.
Thank you. That was really helpful. And don't feel bad about the questions because, we have a big group here and it often happens that that folks are a little confused about one or the other, questions. So that's very much par for the course. And there were lots of comments in the chat as well about how helpful the pictures were in particular. So, sometimes, we have very wordy slides and, and it's good to read them, but it distracts attention too. So having these pictures is really, like they say, right, a picture is worth 1,000 words. And I think for those of us that are, I've heard that expression probing, so many times I never knew what it looked like or what you're actually doing when you take a kid downstairs. So yeah, so thank you. It looks like we might be able to end a little bit early. I don't see any more questions in the chat. but we're happy to take any if anyone has any last minute, or feel free to unmute yourself and ask about, you know, patients you're taking care of or questions that have come up as we've been talking. Okay, well, it looks like we had a lot of questions, but I think we've gone through all of them. Lots of, oh, very funny. Jesslyn says, thank you, Dr. Young. EYE learned and laughed. So yeah, thank you guys for the pun. Thank you for joining. And thank you for sharing your important knowledge and experience with us, because you know these are great take-home points to go back to work with. So thank you.
Oh, thank you. Thanks for having me. Have a great day.
You
Thank
too.
you.
Everyone take care.
Thank
See
you.
you in a couple weeks.
Bye.
Bye-bye.
Thanks, Summer. Thank you. Bye.
Bye. Thank
Bye.
you.